What's up, Rickies? Welcome back to Rotation Ready. If you're new here, subscribe now. We are working through all 9 domains of pharmacy rotations, backed by over 1,200 real preceptor observations I've collected over my 10 years of experience as a clinical pharmacist and as a pharmacy preceptor. Last video, we talked about F1, nomenclature, brand names, generic names, classes, knowing your drug vocabulary cold so that when you're having clinical conversations, it flows. Today, we are on F2, pathophysiology and disease state knowledge. Many of us do not like biological sciences, but pathophysiology and disease state knowledge are imperative for you to master to excel on your pharmacy rotations. A drug name without disease state knowledge behind it is just a word. It doesn't tell you why the patient is on it. It doesn't tell you whether the treatment makes sense. It doesn't tell you what would happen if it were stopped or changed. So F1 gives you the vocabulary, but F2 gives that vocabulary its meaning. And you already know I'm going to illustrate this with a student story. I want to tell you about a student I had on an inpatient rotation, an ICU rotation. We usually have multidisciplinary rounds at 11 in the morning. And before we go upstairs to round with the rest of the team, we would sit together and go through his patients, align on the recommendations, make sure he understood what we were about to walk into with the team. That morning, he was presenting a patient admitted for a heart failure exacerbation, 3+ pitting edema, volume overloaded, the kind of patient you see constantly on an inpatient unit. This was not a rare or complicated presentation. He had the medications listed, he knew diuretics were part of the plan, and then he mentioned salt restriction. I stopped him there, not because salt restriction is wrong information. In an outpatient setting with a stable chronic heart failure patient, it's a completely reasonable long-term management conversation. But this patient was in the hospital, actively volume overloaded, in exacerbation, and that is not the moment for a dietary counseling point. So I asked him, why does fluid accumulate in the periphery during heart failure exacerbation? He stalled. I asked, what is the difference between preserved and reduced ejection fraction? He stalled again. Then I asked, how does right-sided versus left-sided heart failure change the clinical picture? Nothing. He could tell me what to give, but he could not tell me what was happening in the body that made giving it necessary. He had reached for a fact he had learned, salt restriction, without stopping to ask whether it fit this particular patient. And here's what I was thinking sitting across from him. Here's what was going on inside the pharmacy preceptor's mind. He knows diuretics. He knows the drug name. He can say furosemide and write the dose, but he cannot tell me why the fluid is there. He cannot explain what the failing ventricle is doing or not doing that causes the kidneys to retain sodium and water until it backs up into the periphery and shows up as 3+ pitting edema on an exam. He's presenting a chart. He's not yet seeing a patient. So before we went upstairs that morning, I told him, I need you to understand what is happening with this patient's heart, not just what they're doing about it. I want you to put together a full disease state presentation on heart failure, the pathophysiology, how we stage it, how we classify where a patient is hemodynamically, preserved versus reduced ejection fraction, right versus left-sided, warm and dry, warm and wet, cold and dry, cold and wet. You have a week. Come back and teach it to me. And when he came back later that week, I did not expect what he brought, to be honest. He had gone deep. The Frank Sterling curve, the compensatory mechanisms, hemodynamic profiles. He understood then why a wet warm patient is managed differently from a cold and wet patient. He understood why reduced and preserved ejection fractions have completely different treatment approaches. He understood why that patient with 3+ edema needed aggressive diuresis and not a conversation about sodium intake at that moment in their hospitalization. The disease state knowledge he built that week changed how he approached every single heart failure patient for the rest of the rotation. That is the shift F2 is trying to build. Not just knowing what to prescribe, but understanding the why behind it. And I'm bringing this up because this is not one student. This is a pattern I have seen consistently across 10 years of precepting. The student who can name every medication used in heart failure, but cannot explain why those medications work. The student who has memorized guideline-directed medical therapy without fully understanding what the ventricle is failing to do and why that failure produces the fluid overload, the dyspnea, the edema the patient is presenting with. So knowing that we use something is not the same as understanding why we use it. And on rotation, you will be asked why. When a preceptor asks you to walk through pathophysiology, they're not testing your ability to recite a definition. They are checking whether you understand the disease well enough to evaluate the plan in front of you. Whether you can look at a patient, BNP of 890, 2+ peeling edema on furosemide, carvedilol, lisinopril, and spironolactone, and tell them whether this patient is where we want them to be. That requires understanding the disease, not just the drugs. And to prepare for F2, it's different than F1. With F1, I gave you the top 300 drugs and the flashcard and all that jazz. F2 preparation is different from F1 preparation. You cannot close this gap the way you do a drug name gap by drilling a list. Disease state knowledge requires understanding, and understanding requires time. So before every rotation, identify the 10 to 15 disease states you are most likely to encounter in that setting. For each one, work through the same questions. What is the pathophysiology? What is actually happening inside the body? What are the treatment goals? And why does the pharmacologic intervention address the underlying disease mechanism? Do not rely on memorized definitions. A definition tells you what something is called. Clinical understanding tells you what it does, why it matters, and what it means for the patient in the bed. Pay special attention to disease states where severity and setting change the approach. A stable outpatient with chronic heart failure and a patient admitted in acute decompensation are not the same clinical scenario, even though they share the same diagnosis. Take pneumonia, for example. A patient with community-acquired pneumonia, hospital-acquired pneumonia, or a patient with pneumonia on the medical ward or in the ICU, treatment approaches vary. Study those in depth because your preceptors will test it. The students who move fastest on rotations are not the ones who know the most drugs. They are the ones who understand the patient, what is wrong with them, why it is wrong, and what good treatment is trying to accomplish. And to be honest, in understanding all of that, you understand the side effects. You are more likely to intuitively answer the questions that preceptors are going to ask you as you are presenting and working up your patients. So, pharmacology without pathophysiology is like having a tool without a purpose. You can know every drug in the formulary and still not be able to tell me whether the plan in front of you makes sense for this particular patient. That's F2, and it's the foundation that makes everything that comes after it possible. Next video, we are going to talk about F3, drug indication. Knowing the drug name is one thing, knowing its brand and its class is one thing. That was F1. Knowing the disease state is the second thing. Next is knowing which drug, which dose for which patient and why. That's the next layer. That's F3. And that's what's coming up in the next video. Subscribe now if you haven't yet. F3 is coming. Until next time, rookies.